Thank you, everyone. Thank you for joining us for the cervical cancer and screening and prevention. We'll head over. We've got two brilliant speakers with us this evening. And without wasting any further time, we'll move on to our first speaker. Our first speaker is none other than Dr. Nidhi Jha, who's a senior consultant at NOAA South End Fertility and IVF, Delhi. And she'll be talking on the topic role of HPV in cervical cancer. Over to you, ma'am.
Good evening, everyone. Good evening, all of you. It's very cold here in Delhi. I don't know where you are sitting, but very good afternoon. Very good afternoon, Dr. Ruhi Srivastava. Nice to see you again. Now I would like to share my screen. Hello everyone, as introduced already, I'm Dr. Nidhi Jha. I'm Senior Consultant, NOAA South Infertility and IVF, Delhi. And the topic for today is the very burning topic, role of human papilloma virus in CA cervix. January is celebrated as Cervical Cancer Awareness Month. So today with OnQuest, we have got you a very important topic, especially for developing countries like India. So on this note, I would like to start. Sad but true, in India, 200 women die each day due to cervical cancer. Where is cervix in women? All of you know. Just give me a moment. Slide is on auto mode somehow. As all of you know, where is cervix? Cervix is mouth of the uterus, and that is the most important part. And this is the most exposed part of internal. Why is the slide moving automatically?
Ma'am, can you use the arrow keys while changing the slides? Maybe that'll be easier.
No, actually I'm trying that, but it's automatically changing after some time. So I don't know why.
Ma'am, are you double clicking? Otherwise,
I'm not doing anything. Okay, let's see. I think it has rectified. So cervix is the most the exposed area of the internal genital system. So this is the area which is most exposed to external environment, external infection, medication and everything. So this is the exposed area, and that is one of the reasons why it is more prone for cancers. Now, what is cancer? In very brief one slide, uncontrolled growth of abnormal cells in any part of the body, generally due to chemicals, radiation or microorganisms. In our case, it's virus. Cervical cancer disease burden. What is the reason we are all of us sitting here and discussing about cervical cancer? That is because of the increasing disease burden. Cervical cancer is the most common gynecological cancer in women globally. It ranks third among all malignancies for women, like breast cancer, lung cancer also, and uterine cancer in Western world. More common in the younger population of women. Until recently, CA cervix was linked with many viral infections as the cause is the HMV, HSV, etc. Human papilloma virus is now considered as a sexually transmitted disease, particularly types being highly oncogenic as a cause of CA cervix. More than 150 types of human papilloma virus have been described. All of them, I remind you, all of them does not cause cancer. Most of them cause anal and genital warts and less severe infections. Screening of HPV is very important in the prevention and management of CA cervix. Screening is usually done with pap smear sampling and typically begins in young adulthood. Recently, highly specific HPV DNA tests have been developed for the detection and cervical vaginal preparations, etc., which are polymerase chain reaction and hybrid 2 capture test. I'll go in the details of it later. Worldwide, continuing with the cervical cancer burden, worldwide about 5 lakh women acquire the disease annually. About 75 to 85% are from developing countries, in which India also contributes for a very big part. About 3 lakh women die of the disease annually. Incidence has fallen considerably in developed countries, also in developing countries, due to improved public health measures, which includes the screening procedures, lifestyle modification, like increasing hygiene, late marriage, we are abandoning early marriages, and pap smear screening, very importantly. In the picture I have shown cervical cancer disease burden, new cervical cancer cases worldwide, it's 4,93,000. 4,93,000, and in India contributes 1,32,000 of it, which is around 27%, which amounts to a very big significant number. Coming to deaths due to cervical cancer, that also 27% of the whole world death toll due to cervical cancer is in India. That is the reason why all of us are sitting here. Incidence of women of all ages, cervical cancer versus other cancers, cervix uteri is 26%. It's very high. And the second is none other than the breast cancer. Yeah, the magnitude of the association between HPV and cervical squamous cell cancer is higher than that for the association between smoking and lung cancer. Why we are talking about HPV, human papilloma virus, is very, very, very much associated with causation of cervical squamous cell cancer, and it is even more linked with cervical cancer, as it is even more carcinogenic than smoking causes for lung cancer. So that is the reason that human papilloma virus screening in itself will decrease the burden to a very high amount. In 1996, the World Health Association, along with the European Research Organization on Genital Infection and Neoplasia and the National Institute of Health Consensus Conference on Cervical Cancer, recognized HPV as an important cause of cervical cancer. Scientists have identified about 30 HPV types that are spread through sexual contact and infect primarily the cervix, vagina, vulva, penis, and anus. So it's not only causative of cervical cancer, it also causes vaginal, vulval, and penile cancers and warts, anogenital warts as well. Of these, 4 are most often found within the malignant cells of cervical cancers, HPV 16 accounting for about half of the cases in United States and Europe. Just a moment, I'm not able to see the slides. Yeah. Of these, 4 are most often found within the malignant cells of cervical cancer, with type 16 accounting for about half of the cases in the developed countries, 18, 31, and 45 accounting for an additional 25 to 30% of cases. HPV has been implicated in 99% of cervical squamous cell cancer case worldwide. Adenocarcinoma of the cervix are also related to HPV, but the correlation is less pronounced and is age dependent. In women younger than 40 years, HPV was present in 89% of adenocarcinoma, whereas in women aged 60 years and older, HPV was observed in only 43%. Etiology, as already we are discussing human papilloma virus, I'll just share the details. It is first time when we thought of declaring HPV as the etiology of cancer, cervical cancer, was in 1996. The WHO's Internal Agency for Research on Cancer, IARC, has classified it into 3 groups: carcinogenic, which are HPV type 16 and 18, and probably carcinogenic is HPV types 31 and 33, and possibly carcinogenic is other HPV types except 6 and 11. So the most important one is 16 and 18, and the lesser one is 31 and 33, and all others except 6 and 11 are classified under possibly carcinogenic. The commonest strain is type 16, and it can be retrieved in over 80% of CA cervix, especially squamous cell type. Type 18 seen in few cases and usually affect the endocervical glands. Other types involved in cervical changes include, but not limited to, the following types, as in 31, 33, 51, 53, and 35, etc. In developing countries, type 35 may be second to type 16. Pathogenesis. Like most other DNA viruses, HPV uses host cell DNA polymerase to replicate genome and produce virions. Highly virulent HPV produces 2 viral oncoproteins, E6 and E7. Here I want to say that I'll not go in the details of molecular level. I'll mainly talk about the clinical significance and what all is important in the screening. Highly virulent HPV produces 2 viral oncoproteins, E6 and E7. The protein inhibits P53, P21, and RB respectively. 3 potent tumor suppressors. These are tumor suppressors that act to suppress the division of squamous cells as they mature. This is the human papilloma virus. Human papilloma virus is a necessary cause of cervical cancer in 99.7%, which is a very, very, very high causative etiology. And the most important, as I said, are HPV 16 and 18, which are cancer causing. And the second one, cancer causing, is 31 and 33. 16 and 18 only comprises of more than 75% of cervical cancer and more than 50% of vaginal and vulval cancer. Non-cancer causing types are HPV 6 and 11, and these are the cause of 90% of anogenital warts. Coming to the cofactor factor, as we got to know that it's almost 99.7% cases, the etiology is HPV. What are the cofactors? The cofactors are long-term use of hormonal contraceptive. The risk is increased to 3 times if you have used hormonal contraceptive for 5 to 9 years, and it increases up to 4 times of the general population when the usage is more than 10 years. Early initiation of sexual activity. I'll explain in details about what is the reason why are these cofactors increasing the rate. High parity, it's 4 times risk. And tobacco smoking, both active and passive, causes progression of cervical cancer in association with HPV. Other STDs, immunosuppression, HIV infection, multiple sex partner, low socioeconomic status, diet. The reason is diet poor in antioxidants. As we already said, studies suggest that whether women will develop cervical cancer depends on a variety of additional factors that act in concert with cancer-associated HPV types in the process that leads to cervical cancer. Coming to the cofactors, first is early initiation of sexual activity. In addition to sexual activity, age is an important determinant of risk of HPV infection. Most cervical cancers arise at the squamo-columnar junction between the columnar epithelium of the endocervix and the squamous epithelium of the ectocervix. At this site, there are continuous metaplastic changes, which causes the greatest risk of HPV infection coincides when the metaplastic activity is at the greatest. Greatest metaplastic activity occurs at puberty and first pregnancy and declines after menopause. This is the reason greatest metaplastic activity at the squamocolumnar junction is during puberty, in the time of first pregnancy, and later gradually it decreases. That is the reason why early initiation of sexual activity causes there are more chances of cervical cancer. HPV infection is most commonly common in sexually active young women 18 to 30 years. There is a sharp decrease in prevalence after 30 years of age. However, cervical cancer is more common in women older than 35 years, suggesting infection at a younger age and slow progression to cancer. So infection is below the age of 30 years, but the cancer is after the age of 35 years. That's what it suggests, that the progression to cancer is slow. Here comes the role of screening, because the progression to cancer is slow. That's why we have many stages where we can catch the infection and treat it. Persistence of infection is more common with the high risk oncogenic HPV types and is an important determinant in the development of cervical cancer. Immune suppression. How is it important? The primary immune response to HPV infection is cell mediated. Therefore, any condition where the impaired cell immunity is there, in those cases HPV infection is more prevalent. This is more common in cases of any renal transplantation or any transplantation where steroid uses are there. Human immunodeficiency virus diseases increase the risk of acquisition and progression of HPV. So immunosuppression impairs the cell mediated immunity, and that is the reason why human papilloma virus infects more of such patients. Hormonal contraceptive, as we have already read, that hormonal contraceptive also is cofactor with HPV, and it says that the risk is 3 times higher when it's used less than 9 years, and it's 4 times higher when it's used for more than 10 years. So why is that? The upstream regulatory region of HPV contains sequences similar to the glucocorticoid responsive elements that are inducible by steroid hormones such as progesterone, an active component of oral contraceptives, and dexamethasone. So progesterone and dexamethasone are causative. Long-term use of oral contraceptive is a significant risk factor for high-grade cervical disease according to some studies, but not in others. It's not for low-grade cervical infection. Tobacco smoking, both, as we got to know earlier, tobacco smoking, both active and passive, is a cofactor. Local immune suppression induced by smoking, we already got to know that immunosuppression is a period, and it's a condition where there are more chances of HPV infection, or rather any kind of infection. The mutagenic activity of cigarette components have been demonstrated cervical smears and may contribute to persistent of HPV or to malignant transformations similar to that seen in the lung. It appears that smoking is the most important risk factor independent of HPV infection for higher grades of cervical disease. So when we are talking about the cofactors, tobacco smoking becomes very, very important. Smoking shows little or no relationships to low grades of cervical disease. So it is more important in cervical cancer and high grade cervical disease, but lesser importance in low grade of cervical disease. High parity, 4 times risk. Multiple pregnancies were a significant independent risk factor among women with histopathological evidence of HPV infection in biopsy specimens and women with moderate to high grade cervical diseases. Here also High parity, why we are talking about it? High parity at that stage, whenever you are pregnant, there are more squamous metaplastic changes are there. That is the reason that the more number of times you conceive, the more increased chances are there that you will have HPV and progression towards the cervical cancer. HPV variants, it has been proposed that the viral load correlates. This is very, very, very important. It has been proposed that the viral load correlates with the severity of the disease. Means if the viral load is more, the severity of the disease is more, and the viral load, as if it's not a cancer, it's just any viremia like HIV or anything else. Studies using quantitative type-specific PCR for high-risk HPV 16, 18, 31, 33, and 45, and low-risk HPV 6 and 11 have shown that HPV 16 can reach much higher viral loads than other types, and that only for HPV 16 does increased viral load correlate with increased severity of cervical disease. So when we are correlating viral load and severity of disease, it matches maximum for HPV type 16. High risk HPV of all types are able to induce malignant tumors even when they are present at low levels. An important emerging factor in the development of cervical neoplasia is the other variants. HPV variants differ in biological and chemical properties and pathogenicity. The oncogenicity of specific HPV variants appear to vary geographically and also with the ethnic origin of the population studied. One study suggested that because of increased transcriptional activity and changes in the progesterone response elements, Asian variants might have enhanced oncogenic activity compared to European isolates. Studies have shown that infections with multiple types of HPV can occur. Multiple infection rates up to 39% have been seen. So at one time HPV, you might be harboring HPV 16, 18, 31, HPV 6, multiple combinations can be there. The presence of multiple HPV genotypes tends to increase with the severity of cervical disease. So if there is a multigenic HPV, there are more chances of cervical disease. However, the prevalence of multiple genotypes was much lower in cervical cancer tissue samples. Cervical disease, it's more, but in cervical cancer, it's less. The majority of multiple infection contains 2 HPV genotypes, but the samples with 3, 4, or 5 genotypes were also seen. So when we are talking about multiple infection at the same time, maximum is with 2 types of viruses. Cervical cancer is one of the best understood examples of how viral infection leads to malignancy. Infection with high-risk HPV types interferes with the function of cell proteins and also with the expression of cellular gene products. Now, coming to the natural history of HPV and cervical cancer, high-risk HPV types can be distinguished from other HPV types largely by the function of the E6 and E7 gene products. In benign lesions caused by HPV, viral DNA is located. When we are talking about the benign, the viral DNA is located extrachromosomally in the nucleus. In high-grade intraepithelial neoplasia and cancers, HPV DNA is generally integrated into the host genome. In some cases, episomal and integrated HPV DNAs are carried simultaneously in the host cells. Eventually, mutations accumulate that led to fully transformed cancerous cells. In addition to the effects of activated oncogenes and chromosomal instability, there are other mechanisms contributing to transformation, including methylation. I will not go in the details of that. Important here is progression to cancer generally takes place over a period of 10 to 20 years. That's again why we are focusing more and more on screening. We have a long gap in infection to metastasis or infection to full-fledged malignancy. So we have a very long gap, and we can find out cases at different levels of HPV infection. Some lesions become cancerous more rapidly, sometimes within a year or two. So generally it's 10 to 20 years, but more malignant types sometimes even in a year or two it can progress. Natural history of HPV depicted in the picture. HPV infection, cervical lesions ranging from normal to invasive cancer, normal development of precancerous lesions, say CIN 1, 2, and 3, invasive cancer. It is measured by HPV DNA detection in cervical cells. Relative frequency increases with severity of lesions. Similar thing. Persistent of HPV infection, normal cervix, HPV infection progression to invasion, pre-cancer, cancer, clearance, sometimes regression as well. Genetic factor. Genetic factor also is important. A genetic predisposition to colorectal cancer, lung cancer, and melanoma has already been recognized, and it is widely accepted. Genetic predisposition was found to be even greater component in cervical cancer when the same method of analysis was used. So we already know about the genetic predisposition of some cancers like colorectal cancer, lung cancer, and melanoma, but it is also explained in cervical cancer, and even it is more significant. Genetic heritability was found to account for 27% of the effect of underlying factors for tumor development. Here, that is why it is more important to screen female early in the age when she has family history of cervical cancer or endometrial cancer in the family. Heritability could affect many factors contributing to the development of cervix, including susceptibility to HPV infection, ability to clear HPV infection, and time to development of disease. Here again comes immunosuppression. If the person is immunosuppressed, ability to clear HPV infection will be very less. The effect of shared familial environment was shown to be small at 2% and was found only between sisters. It was found only between sisters and not between mother and daughter, which is different from endometrial cancer and CA breast. When acute incident HPV infection, it takes 5 to 10 years to develop cancer from time of infection. Infects only the epithelium, no viremia. Most cases, no histological or cytological changes. Resolution of infection and cytological changes occur secondary to antibodies and NKC activated CD4 and T lymphocytes. When we get the infection and we treat it, the progression is very less. How HPV infection can occur? Through the most common route is through sexual intercourse. I would like to highlight a few points here. Through sexual intercourse, vertical transmission, mother to child, and fomites. Through sexual intercourse, there was one thing that does wearing a barrier contraceptive or condom help you prevention from, does it help in prevention of cervical cancer? The answer is not 100%, because cervical cancer is not only sexually transmitted disease, it is skin related disease. Skin to skin transmission is there. If it can even be transmitted if you are in a close contact, and the partner is using barrier contraceptive, there are still fomites, there are still secretion from anal area and skin to skin contact, which also is the cause of HPV infection and cervical cancer. So it should be highlighted that it does not, the barrier contraception or condom will not protect you from cervical cancer. So this is very important point. This was very important point I wanted to highlight, that using a condom will not absolutely, I am not saying that perfectly, I'm not saying that there is no decrease in incidence, but it does not absolutely prevent you from having cervical cancer. Vertical transmission is also possible from mother to child and fomites. It is found, this is again a very CDC has said this, that it is found that in every 10 women, 8 women might have HPV infection at any time in life. So it is almost 80% female has sometimes HPV infection in her life. It is a very, very, very high number. Symptoms in very brief, all of you know. Continuous vaginal discharge in spite of treatment, foul smelling, thick discharge, repeated vaginitis, UTI, postcoital bleeding, non-healing or recurrent cervical erosion, irregular or intermenstrual bleeding, especially in premenopausal phase. Pelvic pain, bleeding, vaginal discharge. Rare symptoms are bowel bladder issues and back pain. Is it possible to get protection against cervical cancer? So protection is there, and we'll talk about, Dr. Ruhi will talk in details about the cervical cancer vaccination and everything. I'll go in brief. Cervical cancer is now a virtually preventable disease due to early vaccination, screening strategies, long natural history, 10 to 20 years it takes in progression. So long natural history. And cervix is an easily accessible organ. As I said, this is an organ, internal genital organ, which you can see from exterior. So that is also a very important reason why we can screen it. Secondary prevention, screening may help in early detection of cervical abnormalities. What is the use of screening program? Secondary prevention or screening program are helpful in detecting cancer at the early stage, hence useful in saving lives. Tests available. What are the tests available? Visual inspection, VIA, Willi, Pap smear, conventional. These are the conventional methods. Now we are more opted for liquid-based cytology and HPV DNA testing. So I would like to highlight on liquid-based cytology and HPV DNA testing. Why liquid-based cytology is more important than has become more common and more result giving from Pap smear. The reason being see, in liquid-based cytology, what we do, in the Pap smear, what we do, we take, I'll go to the I'll go to the picture and show you. When we are talking about Pap smear cells are scraped from the cervix and examined under a microscope to check for disease or other problems. What we do, we put a speculum, we visualize the cervix, and with a spatula, we take sample from the sample from the cervix. What we do in liquid-based cytology, and then what we do, that spatula, we make a thin slide and then fixate it with a spray. There are fixing sprays, and then we send that sample to the lab for checking. When we do liquid-based cytology, in liquid-based cytology, you all must have seen that there is a cytobrush kind of thing, which cytobrush will goes inside the cervix, and it takes sample even from endocervix, and then we break the upper part of the brush and we put it in a solution given by the supplied already with us, and we shake the brush. So what happens, whatever cells are there are dissolved in that solution, and then when it reaches to your pathologist, they make a slide, and that slide has very less residue, very less. There are during taking the sample, sometimes debris is there, sometimes blood is there. So these they don't obscure the vision of the pathologist or the technician to see, and it is a better sample. There are less chances of drying. If there are times when we are doing Pap smear, and it takes sometimes the slide dries before fixating it. So, and it is a thick film. When we make a film, it is on the slide, it is a thicker film. So there are obscurity in the findings when the pathologist sees it under the microscope. So the preferred thing nowadays is liquid based cytology, which most of us are now practicing in our personal in our screening programs. So other ones are cervicography, papnet, polar probe. These are still experimental, not very commonly used. So now the routine guidelines. The guidelines are here I have taken from US Preventive Services Task Force, and the other one is American Society of Cervical Cancer Prevention. So when we are talking about the US Society, when the patient is younger than 21 years, it recommends against screening. In ASCCP, women should not be screened regardless of the sexual initiation or other risk factors. When we are talking about US PSTF, they say that absolutely you should not screen below than 21 years. And when we are talking about ASCCP, it says that you can screen if the sexual initiation is at very early, even younger than 21 years. So you either, if you have a risk factor in the family, or there is sexual initiation before the age of 21 years, in those cases you can even screen before the age of 21 years. Coming to 21 to 29 years, recommend screening with cytology every 3 years, and similar with ASCCP. 30 to 65 years, recommends screening with cytology every 3 years, or for women who want to lengthen the screening interval, screening with a combination of cytology and HPV testing every 5 years. Here I would like to say that in our clinical practices and where the facilities are available, it's always better to simultaneously to take HPV DNA sample as well. I'll be explaining in the coming slides why it is important. So not only liquids-based cytology, first of all, you should improvise yourself by doing liquid-based cytology rather than pap smear testing wherever it is available. Sorry, it is very important on the resources as well. And you should try to accommodate HPV DNA testing in the same sitting. That improves the screening procedure. So when we are talking about 30 to 65 years by USPSTF, in those cases, they say that if you want to increase the gap, that 3-yearly gap you want to increase, in those cases you can do a liquid-based cytology with HPV DNA testing, and you can increase the gap to 5 years. And ASCP says screening with cytology and HPV testing every 5 years, or cytology alone, it's almost similar. Older than 65 years, recommendations against screening, as we have already read, that metaplastic squamous columnar junction metaplastic changes decreases very less at the after menopause. So they recommend against screening women who have had adequate prior screening and are not otherwise at high risk for cervical cancer. What ASCP says about it: women with evidence of adequate negative screening and no history of CIN2 within the years should not be screened. Screening should resume for any reason if a woman having a new sexual partner. So they say that ASCP differs a little bit from USPSTF, that if the female is sexually active and she has found a new sexual partner, then you should screen even above the age of 65 years. After hysterectomy, what does it say? USPSTF says, USPSTF, again I would like to inform you, it's US Preventive Service Task Force, and ASCCP is American Society of Cervical Cancer Prevention. So after hysterectomy, USPS says recommends against screening in women who had a hysterectomy with removal of the cervix and who do not have a history of high-grade precancerous lesion or cervical cancer. So if it is not above sin 2 or 3, it's not sin 2 or 3, and hysterectomy is done with cervix removal, there is no need of screening. Women of any age following a hysterectomy with removal of the cervix who have no history of SIN2 should not be screened for vaginal cancer. Evidence of adequate negative prior screening is not required. That is different from USPSTF. Screening should not be resumed for any reason, including if a woman reports having a new sexual partner. Vaccinated, HPV vaccinated, if someone is vaccinated, women who have been vaccinated should continue to be screened. This is a very, very, very important point. Every day we get patients who wants to come for the vaccination and who want to get their daughters for vaccination, and they think that after HPV vaccination they do not have to be screened. It is very, very important that even the HPV vaccinated females have to be screened the same way as the general population is, and same with ASCCP. So pap smear, already we have seen how it is done. Disaster prevention is better than cure holds true for cervical cancer. This can be achieved by regular health checkup and regular pap smear test. Pap smear is a cancer screening. This you know, all of you know. Routine pap smear has reduced CA cervix by 75% in developed world. Repeat pap is advised if it shows abnormal cell, and then advise colposcopy and biopsy. Significance you already know. Preventive methods, only less than 1% progress to cancer. Lifetime risk of genital HPV 50 to 80%. Lifetime risk of genital warts is 5%. Pap test is used to find cellular abnormalities in several early diagnosis. These all things you already know. Colposcopy is the examination of the cervix and vagina with the magnifying instrument. Colposcope after the application of vinegar to the cervix. This you all know, and colposcopy in itself is a big chapter, so I'll not go in details of that. Yes, now what is the recent one, why I was talking about HPV and DNA testing? Clinical utility of HPV DNA testing. It has been established that there is a variation in interpretation of ascus pap smear even among expert cytopathologists. For the same pap smear report, they have to define ascus. It's different for different pathologists. In some women, ascus indicates real pathology, and in others, it represents only a vigorous reactive change that is benign. In the United States, I will not go in details of that. I just wanted you to know why HPV DNA is important. Identifying women at high risk by testing for HPV DNA avoids unnecessary colposcopy procedures. Patients with ascus who are positive for high-risk HPV DNA are referred for colposcopy. Those who are negative for HPV DNA undergo a repeat pap smear at 6 months and 12 months. If these are also negative, the woman is returned to a routine screening schedule. Patients with ascus who are positive for high-risk HPV DNA are referred for colposcopy. Those who are negative for HPV DNA undergo a repeat pap smear at 6 months and 12 months. If these are also negative, the woman is returned to a routine screening schedule. So why it is important? I would just repeat this, that it is important. HPV DNA testing is important due to some reasons. First of all, if you want to increase the gap in screening from 3 years to 5 years, you should add HPV DNA to your routine screening procedure. The other thing is it also prevents unnecessary colposcopy. So if you have got early ascus kind of thing and HPV DNA is negative, then you might not have to proceed for colposcopy. So it prevents unnecessary colposcopy, and you can confidently increase the gap between the screenings. So HPV The vaccine is started at 9 years of age, and you can give it at least latest by to 45 years of age. For you and your daughter, a wonderful gift. Guard yourself means protect yourself. Why should she suffer in silence? Give her wings and let her fly. Thank you.
Thank you so much, ma'am. We'll now move on to our next speaker. We remind our audience that our experts would be happy to answer your questions, and we have our Q&A session at the end. So please feel free to put your questions in the chat box. We'll now move on to our next speaker, who's none other than Dr. Ruhi Srivastava, who's a fertility and IVF specialist and Director Ankuram IVF Ranchi. And she'll be talking on the topic role of cervical cancer vaccine, the Indian scenario. Over to you, ma'am. Ma'am, you'll have to unmute your mic, ma'am.
Yes. Thank you so much. And it's a very good initiative by ONCUS. All of us know that it's a cervical cancer month is going on. And as Dr. Nidhi has said that cervical cancer leads to contribute to 27% of all the cancer. So it's a very, it's a good initiative from your part to increase the awareness about the cervical cancer and how to prevent it. So I'm starting my presentation. Just 1 minute.
This meeting is being recorded.
I hope the slides are visible on your screen.
No, it's not visible.
Ma'am, can you come to Zoom? Back to Zoom, you'll have to click on Zoom.
Click on Zoom.
Ma'am, are you able to see Dr. Nidhi?
It's visible. Sorry for the interruption. As it has been rightly said by Dr. Nidhi that cervical cancer is the most common cancer in India, and it contributes to approximately 27% of the whole cancer. That's why we called, and it is very common in India, and that's why we called India is the capital of cervical cancer. And every woman is at risk of the cervical cancer. And it has been found that 1 out of 5 women who die due to cervical cancer in the world is an Indian. And death due to cervical cancer is more than the pregnancy deaths. Please change the screen. So why we are worried? Because cervical cancer is the most common cancer, and this cancer is preventable. And that requires urgent attention. It is estimated that in India, about 160 million women aged between 30 to 59 years are at risk of developing cervical cancer with a fertility rate of 50%. So HPV vaccination forms the base of the cervical cancer control. So primary prevention is done by the vaccination, that is HPV vaccination. Secondary prevention is screening and the treatment of pre-cancer, that has been well explained by the Dr. Nidhi. And the tertiary treatment is cancer treatment and the palliative care.
Ma'am, can you say next slide when you want us to move to the next slide?
Same slide. So does HPV cause only cervical cancer? The answer is no. And why HPV disease need to be prevented in India? HPV is the necessary cause of cervical cancer and the other cancerous lesions around the anogenital region and oral mucosa, besides anogenital warts and respiratory papillomatosis. These things has been explained by Dr. Nidhi, so please change the slide. So what we are doing, according to WHO, it is very necessary to eliminate the cervical cancer in the next 100 years, implementing an effective strategy. Change the slide. So global strategy is towards the elimination of cervical cancer. Vision is a world without cervical cancer. So what is our target? Our 2030 target is that 90% of girls should be fully vaccinated with HPV vaccine by 15 years of age. 70% of women should be screened with a high precision test at 35 and 45 years of age, and 90% of women identified with cervical disease receive the treatment and care. Change the slide. So what is happening in the Western world? So the strategy is 90, 70 and 90. That I have said 90% of the girls should be vaccinated, 70% of the women should be screened, and the 90% of the women should be treated. So in the Western world, what is happening? Out of 90, 50 to 90% of the women is vaccinated, 80 to 90% of the women is screened, and 80 to 90% is treated. But what is the scenario in India? Next. Out of the 90%, only 0.1% of the girl is vaccinated. Only 3% of the woman is screened, and only 10% of women receives a treatment. So what should India do? We should go for the 90% of vaccination, 70% of the screening, and 90% of treatment by 2030. So vaccinating girls against the cancer-causing types of human papilloma virus before the age of 15 is the foundation for bringing every country's incidence rate of cervical cancer down to the agreed elimination level. Scaling up the screening and treatment of the cervical pre-cancer lesion. The evidence shows if 3% of women between the age of 21 to 65 years are screened for cervical cancer, do at least twice at age of 35 and 45 by via or villi, that leads to precancerous lesions are more likely to be detected before they become cancerous. So WHO Global Strategy towards eliminating the cervical cancer aims to set the world on the right track by 2030. But at this pace, global elimination of cervical cancer is not predicted earlier than the 100 years, that is 2130. If no action is taken, cervical cancer death will rise almost 50% by 2030. Cervical cancer is one such fatal disease, but the most important thing is it is preventable. So it is a very good, what we can say in terms of the prevention, that it is a vaccine preventable disease. Change the slide. According to GAVI, that is Global Alliance for Vaccine and Immunization, and WHO, HPV vaccine is a very high impact vaccine. 20 deaths can be averted per 1,000 vaccinated women. And how we can achieve our goal? Our OBG friends and nurses can play a vital role in decreasing the incidence of the cervical cancer in screening and treatment. As per WHO, ACOG and OBG and nurses play a critical role in women's care and should vaccinate the adolescent girls and young women with HPV vaccine during the catch-up period. Now, what are the reasons why we are so much thinking to vaccinate the adolescent girl is important? Because there are 4 things. If we vaccinate the adolescent girl, higher immune response in adolescent age occurs as compared when they are young adults. Second is immunization before the exposure can be given highest possible efficacy. The third is high risk of acquiring HPV even with first male partner, and the cost of immunization is less in most of the adolescents who just need 2 doses. And also why young age is why the adolescent age is important, because exposure to HPV virus at a young age increases the risk of cervical lesions and cancers in women. Relative risk for CIN and invasive cancer increase with decreasing age of first sexual intercourse, and it has been found that it is 5 times higher risk of invasive cancers if the first intercourse occurs before the 18 years of age compared to after 22 years, compared to as 22 years. Now, 4 reasons why OBGs should prioritize the HPV vaccination in girls or women. According to FOXI or API, recommends vaccinating the girls or women at various stages in their lives with relevant vaccines. India has a huge female population between age of 9 to 45 years, that is 367 million, who are eligible for the HPV vaccination, but most of them are not vaccinated. OBG
Ruhi ma'am, can you hear us?
I think there is some connectivity issue on this.
Yes, ma'am.
FOGSI and API recommends vaccinating girl women at various stages in their lives with relevant vaccines. India has a huge female population, as she said. As all of us know, that we are a young country. So 9 to 45 years females count for 367 million who are eligible for HPV vaccination, but most of them are not vaccinated. Gynecologists have an opportunity for catch-up at HPV vaccination because women come to you with various complaints throughout their life. Gynecologists see, treat, and hence know the damage cervical cancer can cause to the women and ultimately to the family. First of all, about all this, being a gynecologist, all of you know that how close you are with your patients, and generally the obstetrics runs in the family. So you must have treated the patient, you must have treated even sometimes their mother, and you will be treating the daughters. So they are very close to you. So whenever they come to you for any visit, you can counsel them and you can motivate them for, you can even motivate them for being vaccinated and start getting vaccinated, and they eventually counsel their family members for vaccination. So we have patients, very commonly we see patients that they get their younger daughters between 9 to 15 years of age to come out and get vaccinated with us. So we obstetrician and gynecologists are very close to the society females, and that's why it's always better when they come to you to counsel them regarding all this. So we'll wait for Dr. Ruhi.
Yes, ma'am. She's.
So I think I have read this slide. Please
yes.
This meeting is being recorded.
Move on to the next slide.
Now, what are the 4 reasons to counsel and offer the HPV vaccine to postpartum patient? HPV infection may occur or persist during pregnancy because of the changes in the hormonal and immune response. There is a high HPV prevalence in postpartum women, and only few women were positive for one or both oncogenic HPV type. So majority of this group can still benefit from HPV vaccination. Postpartum HPV vaccination is associated with favorable rate of vaccine completion. Postpartum administration of the HPV vaccine is feasible and is associated with a high degree of satisfaction among the women. But the important thing is that I'm going to discuss it later. There are 3 types of vaccine available. But among those 3, only Gardasil vaccine can be used and not Cervax vaccine. Please change the slide. So in India, gynecologists see the majority of girls once the girls married and pregnant. So counseling and offering the HPV vaccine to postpartum women could be an effective strategy to increase the uptake and so that we can reach the goal by 2030. ACOG, CDC and WHO guidelines on the HPV vaccination during lactation. What ACOG suggests? According to ACOG, the HPV vaccine can be given to postpartum and the breastfeeding woman. According to CDC, HPV vaccine can safely be given to women who are breastfeeding. And what WHO says? Breastfeeding is not a contraindication for HPV vaccination. Available evidence does not indicate an increased risk of adverse events linked to the vaccine in either the mother or their babies after the administration of HPV vaccine to lactating females. Now, HPV vaccine and infertility. According to GACVS, that is Global Advisory Committee on Vaccine Safety, they have concluded that the available data do not support an association between HPV vaccination and infertility or primary ovarian insufficiency. Now, the important question is why protecting boys against HPV is important. Because most HPV infection clear on their own, but persistent infection can lead to the cancers, lead to certain cancer or other diseases in males also. In males, the HPV infection persists in their whole life. What is the HPV prevalence in male in India? The HPV prevalence among men in India is 26.7%. In the cohort study where their spouses are suffering from cervical cancer, it has been found that HPV prevalence among the male is 66.7%. That is quite high. So CDC advises not only rely on the cervical cancer screening, but to protect women with HPV vaccination now. Cervical cancer is the only type of HPV cancer for which there is a recommended screening test. Pre-cancer for other HPV-related cancer, except cervical cancer, may require invasive testing and treatment, and the 90% of HPV cancers are preventable with HPV vaccination. Now, HPV vaccine. So what is the rationale or what is the basics for vaccination? Because natural infection occurs, it induces a weak antibody response. But when the woman or male or female is vaccinated, it induces the vaccination induces high antibody response, and the higher antibody level at the cervical epithelium prevents the HPV infection. Now, what these vaccines, these vaccines are? These are the recombinant L1 capsid proteins that form the virus-like particles. These are non-infectious and non-oncogenic, and they produces higher level of neutralizing antibody than the natural infection. Now, FDA has approved 3 vaccines. The first one is Cervax. This is a bivalent HPV vaccine. This covers against the human papillomavirus 16 and 18, and we can give to the females between the age group of 9 to 25 years. The second one is Gardasil. It's a quadrivalent HPV vaccine, and it covers the virus, human papillomavirus 6, 11, 16, and the 18. And we can give it to the males and females of 9 to 26 years. And the recent advancement is Gardasil 9 that has been approved in 2014 by the FDA. It's a 9-valent HPV vaccine. It gives protection against the 9 strains of human papillomavirus, that is 6, 11, 16, 18, 31, 33, 45, 52, and 58. And we can give both to the males and females between the age 9 to 26 years of age. And this Gardasil 9 is now available in India from September 2021 also. So what are the doses to be given? Recommended HPV vaccination for adolescents as per WHO, CDC, FOXC, and API. If the right age to give the vaccination is between 11 to 12 between 11 to 12 years of age, if the vaccination is given before 15 years of age, the recommended dose is only 2 doses. That is given between the interval of 6 months of gap. And if a girl is vaccinated after 15 years of age, the dose required is 3, total 3. That is 0, 2, and 6. So, HPV vaccine is best at 11 to 12 years of age. Preteens have a higher immune response to HPV vaccine than the older teens, and it ensures immunization is completed prior to potential exposure. And it has been found that antibodies produced are highest between the ages of 9 to 15 years. And experts are silent on this level, but it is very good to vaccinate the girl at the age of 11 to 12 years of age, so that we can get the maximum higher immune response at this early age. Now, talking about the safety of these vaccines, the most common adverse event reported were considered mild. For serious adverse events reported, no unusual pattern or clustering that would suggest that the events were caused by the HPV vaccine. These findings are similar to the safety reviews of MCV-4 and Tdap vaccine. And since 2006, 57 million doses of HPV vaccine has been distributed in USA. So at the end, I can say that HPV vaccine is very safe. We can go for it. To make significant, as I have previously also explained, the newer vaccine, that is Gardasil 9, has been introduced to cover the maximum strain of the HPV virus. And this has been written in this slide also to make the significant impact of the HPV diseases, burdens, and cancer. Broad serotype coverage is required. This is a 9-valent HPV vaccine that has I've been explained, and I was talking that it has been introduced in India since from 2021. It is not available. So can 9-valent, the recent vaccine, HPV vaccine, can help to reduce the HPV-related cancer burden in India? Yes. 98.4% of the cervical cancer attributable to 9 HPV serotype, as again 90% of the global. 95% of the vulval precancer cases attributable to the 9 HPV serotypes, and 77% of vaginal precancers, that is attributable to the 9 HPV serotypes, and 73% of anal cancers attributable to the 9 HPV serotypes. These can be decreased. Now, the safety profile of this recent vaccine. Immunogenicity, concomitant administration of the 9-valent HPV vaccine with the other vaccine did not interfere with the antibody response to any of the vaccine when compared with the non-concomitant administration. The safety profile, the overall incidence of adverse event was generally comparable in the concomitant versus non-concomitant group. So why it is important to go for this newer vaccine? Because the chance of a woman being infected with all the 4 types of HPV vaccine included in the QHP vaccine is very low. Majority of the sexually active women can get benefit from the QHPV vaccination. QHPV has proven effectiveness that provides long-term protection for age group from 24 to 45 years and 0% breakthrough cases even after 10 years of vaccination. Now, 4 reasons to choose QHP vaccine. It is efficacious even in mild adult women. It has proven effectiveness that provide long-term protection, established evidence in lactating mothers, and assured core licensure safety profile. So I'm at the end of my session. While protecting women, Government of India should not miss out the single adolescent girls, the appropriate age with less cost. And while protecting girls, parents should consider vaccinating also the adolescent boys with Gardasil 9 or 4, age between 9 to 15 years is the appropriate age. So protection from HPV cancer is priceless. Thank you so much.
Thank you so much, ma'am. We'll now move on to the next part of the session. We've received a few questions from our audience, and I have just displayed them. With your permission, I'll start reading the questions. Will sexually active women benefit from the vaccine?
Yes, definitely. The sexually active, because ideal thing is we should vaccinate the woman before she becomes the sexually active. But if she is not vaccinated, we should not defer any woman from vaccination. If she is sexually active, we can she should go for the vaccination.
Should the gynac advise LBC plus HRH PV DNA, or should await LBC and go ahead with add-on?
I would like to answer this question. This is a very relevant question. Ideally, why it is not in HPV DNA is not recommended everywhere, because it's expensive. So if in India, most of the time, the patient is paying from their pocket. So it 100% depends upon the affordability of the patient, that ideally, if the patient is affordable, in the same sitting, you should do liquid-based cytology and HPV DNA, because it goes with the same sample. You don't have to take two samples. The liquid-based cytology sample only will detect the HPV DNA as well. But sometimes when your patient is not that affordable, you can divide it in two steps. Send their liquid-based cytology, and if it comes high grade, you can send for HPV DNA. But in my routine practice, and most of us, we in Delhi, we try to incorporate it in one setting, because it's less difficult for patient. Yes, it costs it's not that expensive. So ideally, if the resources are available, you should accommodate both the testing in the same sitting. And I have seen patients where ascus is not there, LCL is not there, but still HPV DNA is positive, and cervix is bad, otherwise bad. Erosion is there, discharge is there, and it's not looking healthy to you, and HPV DNA is positive. In that case, that is the reason why I always try to do it in same sitting. But yes, if the patient is not affordable and not willing, then you can do it in two settings.
Ma'am, can pregnant women get the vaccine?
No, the vaccine is not recommended for the pregnant woman. Studies has not shown that HPV vaccine cause any problem to the babies, but in pregnancy still the recommendation is not there to give vaccine to the pregnant woman.
So the summarizing of the answer, that you should not give it in during pregnancy, but it can be given postpartum. Do you agree, Dr. Ruhi? You can give it postpartum?
Someone can get infected with HPV.
Is there any certain age after which?
Yes, as I have told, the concept of vaccination and activation.
Dr. Ruhi. Is there any certain age after which someone can infected with HPV? Certain age, as earlier only I said, that it's almost a sexually transmitted disease. So it is transmitted sexually. So no age is defined. It depends on how early the person has started having sex. So there is no there is no time, age, or limit given, that
Yes,
it's not given. It's not given. So it depends on how early or how late the patient start being sexually active. Dr. Ruhi, are you there?
Yes. Hello.
Switch on your camera, please.
Just 1 minute.
Sorry, ma'am. I will just. I believe your network is a little slow. Please go ahead, ma'am.
How long can you live after being diagnosed with cervical cancer? It's a very, it's a little vague question because it depends on the diagnosis. It depends on the stage at which you are diagnosed with cancer. So it can be even, it will not reduce your lifespan if it is diagnosed at early age, at early stage. And you may not survive even for 1 year if it is diagnosed in advanced stage. That's where the screening of cervical cancer comes. That because the progression of disease takes 10 to 20 years, so we have a ample amount of time to screen you in the earlier stage. So the answer of the question was that it varies on what stage you are diagnosed or what stage your patient is diagnosed. Good question. Can you get pregnant after diagnosed with cervical cancer? It's if you are stage 2, stage 3 early, you are diagnosed cervical cancer. I think it's difficult to conceive and continue the pregnancy. There are cases when you get you diagnosed when you are pregnant. When you are already pregnant, I have seen a patient when she was diagnosed when she was around 6 months of pregnant, and she delivered a healthy child. It was diagnosed early. It was the incidental finding in some of the ultrasounds, and the reason was the reason it was diagnosed early. And for some reason that biopsy was done, that pap smear was done, because the cervix was not healthy and it got diagnosed, and the patient delivered a healthy child, but it was the cesarean section was done to deliver the child. But generally they are not advised to be pregnant. If it's very early, then they can get pregnant, but otherwise it's not advised. Dr. Ruhi, this question is for you.
No, no booster dose is required. I have said that there is no booster dose required because the vaccine is protective for the whole life. Or yeah, only 2, as I have said, that only 2, if the vaccination occur before the age of 15 years, there are only 2 doses, and after 15 years, 3 doses is required.
So no booster dose. It's better than a COVID.
Thank you so much, ma'am. Those were our questions. I would now request Mr. Shashi Sinha to please give the thank you note. Over to you, Mr. Shashi.
So, Kashish, if you permit me, can I just try to share my screen? I've made a couple
of... Please go ahead, sir. Please go ahead.
Yeah. So, is the screen visible?
Yes, it is. Yes, it is.
Yeah, so very good evening, Dr. Nidhi Jha, Dr. Ruhi. Thank you so much for a very informative session. And it was really a lot of information that I guess must be very useful, not only for me and my family members, but for everybody who's also watching this live streaming. So thank you on behalf of Onquest Laboratories. Thank you once again for being on board. Now, I'll just take a couple of slides. I wouldn't take more than a couple of minutes because I know it's been an extended session. So just allow me. So we are Onquest Laboratories, and we are India's leading super specialized laboratory network. And while everyone talks about quality in the periphery, we actually have been practicing it since the last 20 years. And what we started as a research organization under the Dabur Research Foundation. And we have developed into a full-fledged diagnostic industry. Our specialized, we have a very specialized national network, and our typically the journey for all the players starts from getting into routine diagnostics and then getting into specialized and the super specialized segment. So our journey has been the reverse one, wherein we started with being one of the leaders in the specialized diagnostics, and now we have an extensive foray into the routine diagnostics as well. So these are some of the key business areas, or I would say the service areas that we have: the specialized, the routine, the wellness programs for families and corporates. We are also one of the leading players when it comes to hospital lab management, and we are into clinical trials, and we also have our own R&D department. Some of the USPs: we are backed by the Berman's family. You would all know they are the same promoters of Dabur, and we inherit the same values and trust and commitment of Dabur. We have a scientific team who combined experience exceeds about 800 years. Of course, we follow all the quality norms, and we have been the pioneers in bringing many high-end international technologies in this country. And for this session, I guess the most important thing is that we are also the leaders in onco testing. And it's a personalized service with our partners and clinicians that actually scores and one of the main USPs that we have. We are known for final diagnosis and specialized phlebotomy for pediatrics and senior citizens, and we are renowned for giving the most accurate reports. There has been an extensive journey starting from about 20 years back. I wouldn't get into the details of this. We got into various departments and key technologies. Notable one was we also got the CAP accreditation and network expansion. Recently, in 2020, we acquired the Quest Diagnostics trademark facility, the reference lab, which they had in Gurgaon, and I'm currently speaking from that particular office only. So that has given a huge boost to our clinical offerings as well. We have, in fact, best in quality management practices. We have all the accreditations, the internal audits, and we go for third-party audits as well. There's an extensive range of about 4,000 odd tests that we cover, ranging from the specialized to the retail segment. We have an in-house R&D. These are the sub-points. I wouldn't get into the details of this. We are also very much into clinical trials and patient support programs. If anybody has a lead or if you wants to be associated with us, most welcome. Amongst the series of awards and recognition, the recent one we got was just a month back, wherein we were awarded the Excellence in Medical Services as the Diagnostics Company of the Year, and at the Ayushman India 2021. And finally, I would say that once going through the current program, and there's a lot of learning, and I've realized, and we at OnQuest do believe that ignorance is definitely not a bliss. So there's a lot of awareness that we must have, and that is something that will actually help us in keeping cancer at bay, and especially with respect to the cervical cancer. So we will continue support to the patients' awareness programs, and we will be launching a pan-India awareness program soon, and we will be needing all your support. Thank you so much.
Thank you so much, Mr. Sashi, for such a guided tour of the lab. And I have been associated with OnQuest since quite a few years now. And you are giving very good services, basically because I'm an IVF specialist. So you are giving amazing services in infertility assessments, like hormone reports, and timing of the reports are very accurate. We need it in few hours, and you get it done in those hours.
Sure.
And regarding NIPT testing and many others, dual marker, quadruple marker. So yes, we have all your support, and nice doing these awareness programs with you. And thank you very much for having us here.
Thank you,
And
Dr. Nidhi.
I would like to congratulate and I would like to thank you very much for such an interesting audience, such an interactive audience, and it was nice being.
Thank you, Dr. Nidhi. Thank you, Dr. Ruhi, and thank you all the clinicians who are there currently, beaming live. So we'll continue support to the cancer awareness programs and for the patient awareness programs. Thank you so much. And like I said, we'll all be needing all your support. Thank you so much.